Okay, we're going to get started on part 2 of the abdomen, looking at examination findings. So it's helpful to have a good light, of course. Make sure that your patient is fully exposed so that you can carefully examine their abdomen and that they have an empty bladder. Some supportive pillows under their knees are usually helpful to reduce any kind of stress on the abdominal musculature. You'll need a stethoscope. You may need a ruler for measuring certain things, and sometimes you may need a marking pen, especially if you're going to be evaluating the liver span and excursion. It's important to remember the landmarks on the abdomen. There are 4 quadrants of the abdomen. Basically, the navel is at the center of the horizontal and perpendicular lines that divide the abdomen into 4 quadrants. And remember, there's the right upper and lower quadrants and the left upper and lower quadrants. There are also the abdomen can also be divided into 9 regions. Basically, by dividing the abdomen with 2 horizontal lines and 2 vertical lines. So the 2 horizontal lines across the lowest edge of the costal margin and across the edge of the iliac crest. The 2 vertical lines run from the midclavicular line on either side of the sternum to the middle of the poupart ligament, approximating the lateral borders of the rectus abdominis muscles. The reason it's helpful to think about the quadrants is because it will help you in determining your differential diagnosis to consider which quadrant the pain or issue may be occurring in. This is a picture of the 9 different regions of the abdomen. As you can see, they're called, the 1 is the epigastric region, 2 is the umbilical, 3 hypogastric, 4 and 5 would be the right and left hypochondriac, the 6 and 7 would be right and left lumbar, and 8 and 9 right and left inguinal. If you look at these 9 regions, it's helpful to remember what is in each region, which organs may be in each region. As part of your differential diagnosis, it's important to remember this. So in the right upper quadrant, we have the liver, the gallbladder, the tip of the right kidney, and the diaphragm. Epigastric area is where we encounter issues with the stomach and pancreas. Left upper quadrant, spleen, and part of the pancreas and tip of the left kidney. In the right and left lumbar, we have very few organs are really located there. In the umbilical area, we have the uterus, the bowel, and the aorta. Left lower quadrant is either the left ovary or the bowel. Right lower quadrant, the appendix, right ovary and bowel, and then, of course, the suprapubic includes the bladder and the uterus. Okay, inspection, look at surface characteristics of the abdomen, including the skin, the venous return, lesions, scars, tautness, striae, etc. Pay attention to the contour of the abdomen, looking at it from the side, the abdominal profile from the rib margin to the pubis. So that's why on your checkoff sheet it says that you look at the abdomen from the side, because you want to look at the contour of the abdomen. Looking for symmetry and surface motion. Inspection includes movement. Smooth, even movement should occur with respiration. The patient who's afraid to move or limited movement may indicate peritonitis. surface motion from peristalsis can be seen as a rippling movement across the section of the abdomen. You can sometimes see this in thin individuals, but it can also be a sign of intestinal obstruction. Marked pulsations can occur as the result of increased pulse pressure or abdominal aortic aneurysm. So you want to pay attention to those kind of movements. Your next step is auscultation. Remember, in the abdomen we auscultate before we percuss or palpate. We're going to be listening for bowel sounds, the frequency of bowel sounds, the character, whether they're hypoactive, hyperactive, normal active, etc. Usually heard as clicks and gurgles that occur irregularly and range from 5 to 35 per minute. They're generalized, so most often they can be assessed adequately by listening in one place, although you want to listen in all 4 quadrants. Loud prolonged gurgles are what is known as borborygmi or stomach growling. So borborygmi, you can impress people at parties with that word. Increased bowel sounds can occur with gastroenteritis or early intestinal obstruction, or when people are particularly hungry. High-pitched tinkling sounds suggest an intestinal fluid and air under pressure, as in an early obstruction. Decreased bowel sounds can occur with peritonitis and a paralytic ileus. And absent bowel sounds, referring to an inability to hear any bowel sounds after 5 minutes of continuous listening, are typically associated with abdominal pain, rigidity, and are a surgical emergency. Okay, we're also going to be listening for friction rubs. These are high-pitched sounds that are heard in association with respiration. You're going to use the diaphragm of your stethoscope. It's rare to hear any friction rubs in the abdomen, but we want to listen for that. This can indicate inflammation of the peritoneal surface from tumors, infections, infarction, etc. And then we're going to also listen for friction rubs over the liver and spleen. Bruits can be harsh or musical. They reflect blood flow that's turbulent and indicate some sort of vascular disease. You can hear abdominal bruits as well as cardiac bruits. These abdominal bruits are heard best with the bell of the stethoscope, so part of your abdominal exam is to use both the diaphragm and the bell to hear these different sounds. Bruits are well localized, and we want to listen over the particular areas where we can hear the vascular sounds in the epigastric region and over the aortic area for the aortic bruit, over the renal arteries and the iliac and femoral arteries for bruits. Here's a picture that shows you where you should be auscultating for these different types of abnormal sounds. As you can see here, the femoral area is lower here. The left and right iliac artery are just below the umbilicus. The renal arteries are just adjacent to the epigastric area. Right at the epigastric area is the aortic artery. We may also hear a venous hum, which is a soft, low-pitched, and continuous sound heard best with the bell of the stethoscope. This can occur with increased collateral circulation between the portal and the systemic venous systems, most often heard in the epigastric region around the umbilicus. The next step is percussion. As I was talking about before, it does take a while to get good at percussion. So you want to practice that skill. You can use your finger, as I was describing earlier. You can also use your reflex hammer. I'm using the reflex hammer here. It's a little bit easier on your fingers than using your other finger. And it's also, you can hear better. So remember to put your finger firmly against the abdomen or whatever you're percussing. And then using either the middle finger of your opposite hand. That's my finger. That's the reflex hammer. And remember, if you don't press hard, it's different sound. You can't hear as well. Percussion is used to assess the size and density of organs, to detect whether there's fluid, such as in ascites, the presence of air, like the gastric distension, and the presence of fluid-filled or solid masses. This is a very important skill to master. You want to percuss all quadrants or regions of the abdomen to get a sense of the overall tympany and dullness of the abdomen. We also can percuss the liver span. Usually you start low in the abdomen and percuss up towards the ribs, and then starting at the mid-chest and percussing down towards the umbilicus along the mid-clavicular line will give you the liver span. The liver is usually approximately 6 to 12 centimeters in this mid-clavicular area, which is about 2.5 to 4.5 inches in length. That's what a normal liver should be. We also percuss over the spleen, the gastric bubble, and the kidneys, usually to assess for tenderness or pain, which is usually performed while examining the back rather than the abdomen, because remember, the kidneys are retroperitoneal. This is a pictorial diagram of how to percuss the liver size. So we're starting at the lower edge here and percussing up, and starting at the middle of the thorax and percussing down. You'll hear a difference in the sound quality as you go over solid organs versus air-filled lungs or gas-filled abdomen. So you can definitely hear the change in the sound when you get over the liver. So you percuss over the mid-clavicular and the mid-sternal areas. Another helpful test to determine the liver size is what we call the scratch test. This is a good way to actually begin to learn where the borders of the liver are. You can do this by placing the stethoscope over the liver. Usually you place it like around up in here. Oops, sorry. Around here, just above the liver, or right at the liver edge, but be sure and place it between the ribs themselves so that you're not listening over bone. So you're going to start down here with your index finger and begin to scratch the abdomen in just little linear area scratches like this, and moving upwards towards the head until you hear the sound of a change in your stethoscope. So as you scratch here, you'll be hearing more of a hollow sound, and it'll change once you get to the border of the liver. And you'll be repeating the same procedure both medially towards the middle and laterally to get the size of the liver. The sound is going to be dull and louder over the liver. Here's a basic picture of how you do the scratch test. Then next is palpation. So we've done inspection, auscultation, now palpation. You start with light and then moderate and deep palpation after that. Light is a systematic palpation of all four quadrants, avoiding any areas that have already been identified as problem areas. And you're basically just kind of feeling for any masses or any abnormalities or any pain, and then you're going to go more deeply. Sometimes you need to use both hands, one on top of the other, to palpate more deeply. You're going to put moderate and pressure and gradually go deeper with your moderate to deep palpation. This is necessary to thoroughly delineate abdominal organs and to detect less obvious masses. If you do locate a mass, you're going to want to identify and note the location, the size, the shape, what it feels like, or the consistency, whether there's tenderness, whether you see pulsations, whether there's mobility, and if there's any movement with respiration. Next, with palpation, you're going to do palpation of the umbilical ring and around the umbilicus. This area should be free of bulges and nodules or granulation, and it should be round and free of irregularities. The umbilicus may be either slightly inverted or everted, but it should not protrude. Specific organs and structures in the abdomen: the liver, gallbladder, spleen, left and right kidneys, aorta, and bladder. All right. Some additional procedures that you may use at various times is to evaluate for ascites. Ascites is a pathological increase in fluid in the peritoneal cavity. You're going to be percussing for dullness and resonance, shifting dullness, and fluid wave. And in your textbook, there's a really good picture of the fluid wave assessment. You're also evaluating pain oftentimes in the abdomen, because pain is a very common abdominal complaint. The first thing you want to ask is, quality and what kind of pain is it? Is sharp, dull, stabbing, etc. How bad is it on a scale of 1 to 10? Has there been any recent trauma? If the patient is unwilling to move, then that's a really good indication that the pain is severe. Whether it's accompanied by nausea or vomiting, whether there's a localized area of tenderness. Always be sure that you're watching facial expressions during palpation, because a lot of times people will say that the pain is extremely severe, yet whenever you are palpating, there's no change in their facial expression whatsoever. This is particularly important in children and adolescents and people who you think may be faking the complaint. Common causes of abdominal pain include appendicitis, cholecystitis or gallbladder problems, pancreatitis, a perforated ulcer, diverticulitis, intestinal obstruction, volvulus, and peritonitis. You can also have salpingitis or ovarian cysts and inflammation or infection in the pelvic area, pelvic inflammatory disease, ruptured ovarian cysts, kidney stones, and splenic rupture. Here's some common sites of abdominal pain where you would typically see these different kinds of pain. As you can see, more up in the epigastric area, and above that is heartburn. Gallbladder is more in the right upper quadrant. Liver is typically just along the rib border. Peptic ulcer is more just above the umbilicus. And then you have intestinal pain, which is more umbilical area. Kidney stones oftentimes can also occur in this area as they move along the ureter. appendicitis, the right lower quadrant. Diverticulitis is typically going to be more left lower quadrant, and then bladder is going to be more suprapubic here. There are some specific abdominal signs that you want to be familiar with. With appendicitis, you may have what's called the Aaron sign, or pain in the heart or stomach with palpation of McBurney's point. In peritonitis, you may have what's called the balance sign, which is fixed dullness with percussion in the left flank and dullness to percussion in the right flank that disappears on change of position. Blumberg, also known as rebound tenderness, is often seen with appendicitis and peritonitis. Rebound tenderness is basically whenever you press on the left lower quadrant, there's pain in the right lower quadrant. When you press down and then release is when the rebound or the pain is felt. That's rebound tenderness. There are a couple of other signs that are typical more with abdominal trauma. One of those is Cullen's sign, which is ecchymosis around the umbilicus that can be seen with blood in the peritoneum or with pancreatitis or ectopic pregnancy. Intussusception, basically what's called dance or no bowel sounds in the right lower quadrant. Gray-Turner sign is ecchymosis on the flanks, and that's usually because of blood also in the peritoneum or pancreatitis. Kerr sign, which can be an indication of spleen rupture, renal stones, or ectopic pregnancy, is abdominal pain that radiates up into the left shoulder. McBurney sign, which is classic appendicitis, which is rebound tenderness and sharp pain when McBurney's point is palpated. Romberg Hauship is specific for strangulated obturator hernia, which is pain down the medial aspect of the thigh to the knee. Rovsing's sign is also indication of either appendicitis or peritoneal irritation, which is pain in the right lower quadrant, which is intensified when you palpate in the left lower quadrant. So in other words, if you press in the left lower quadrant, the patient will feel the pain more in the right lower quadrant. That's what we call Rovsing's sign. Here's a picture of the Gray-Turner sign, the ecchymosis in the flank area. The Cullen sign, or ecchymosis around the umbilicus. Here is McBurney's point right here where the arrow is. So you can see if you drew a line from the umbilicus to the iliac crest, right here is where McBurney's point is. These are some videos that I want you to watch on your own. Let's see. They basically will show you the different signs. Murphy's sign, Rovsing's sign, rebound tenderness, the psoas sign, and the obturator sign. All are signs that would need to be evaluated if you're trying to rule out specific things. Murphy's sign is typically used to rule out or to evaluate for cholecystitis or gallstones, and then these others are used to evaluate for appendicitis or peritonitis. Another important test to do when you're evaluating for appendicitis or peritoneal irritation is to actually have the patient stand on their toes and then come down on their heels, and when they hit their heels after standing on their tiptoes with their knees straight, they'll have severe pain in the abdomen. That's what we call the heel strike or Markle's sign. Murphy's sign, again, is positive with cholecystitis or gallstones, and that's basically pressing on the liver area. And when you do that, basically you have the patient breathe in, and then abrupt cessation of inspiration when the fingers are pressed under the rib cage to palpate the gallbladder is a positive Murphy sign. The iliopsoas muscle test is performed when you suspect appendicitis. You want to raise the leg from the hip against resistance. The obturator sign is our muscle test, is also used when you suspect appendicitis or a pelvic abscess. The right leg is flexed at the knee and hip and is rotated laterally and medially. This is the obturator muscle test. Also, ballottement is a palpation technique used to assess an organ or a mass to see if it moves. You can also use the same technique when you're evaluating fluid on the knee, but it's called ballottement. It means if it kind of like floats whenever you push on it. Here's a picture of the iliopsoas muscle test. The patient is raising the leg from the hip while the examiner pushes down against the leg. This should cause pain in someone with appendicitis or peritoneal irritation. The obturator test, again, you're going to flex the leg at the hip and knee and rotate laterally and medially. This is the obturator test. And that stretching of that muscle will cause pain in peritoneal irritation. Other findings in peritoneal irritation include involuntary rigidity of abdominal muscles, tenderness, guarding, trying to keep you from pushing on them because it hurts too bad, absent bowel sounds, positive iliopsoas or obturator test, rebound tenderness, abdominal pain on walking, and the heel test, the positive heel jar test or Markle sign. Right lower quadrant pain that is intensified by left lower quadrant palpation. That's the Rovsing sign. These are some symptoms or signs that can be listed in other systems related to the abdominal exam. So you can see here you can have aortic dissection and have symptoms in the abdomen that are related to hypertension, orthostatic hypotension, fluid volume loss, bruits, aortic dissection, aortic aneurysm, dissection of these other arteries, spleen, renal, iliac, femoral, etc. So just review this. Again, flank tenderness can be a sign of renal inflammation, pyelonephritis, renal stone, renal vein thrombosis. Leg edema can be obstruction in the iliac area or pelvic area, renal or liver disease. Lymphedema, lymphadenopathy can be due to renal vein thrombosis, hepatitis, lymphoma. Jaundice can be related to mononucleosis, liver or biliary disease. So a lot of these signs are listed in other symptoms, but they are related to your abdominal exam. Okay, let's talk about infants and children. Inspection. We want to look at the shape, contour, and movement also of the abdomen, pulsations, peristalsis. In infants, newborns, we look at the umbilical cord. We look at muscle protrusion. Listen for bowel sounds in the chest as well as in the abdomen in infants and children. This can suggest diaphragmatic hernia. Bruits or hums should not be heard in the abdomen of children or infants. You're going to expect more tympanic sound in children. You can often feel the spleen, the tip of the spleen, and often the liver as well in children, but pain is sometimes difficult to assess in children. Techniques of abdominal examination of the adolescent are usually the same as those for adults. There are a couple of little techniques that you can use for people who are ticklish. Basically, one of those is to have them press their hand on their abdomen with your hand over their hand, and that cuts down on the ticklishness of someone because they're basically touching themselves. And don't overlook the possibility of pregnancy as a cause of abdominal pain or lower abdominal masses, even in young adolescent females. In pregnant women, bowel sounds will be diminished as a result of decreased peristaltic activity. You'll see you'll also may see the midline band of pigmentation, which is called the linea nigra, and that may be present in a lot of women. Increased pigmentation there. Many gastrointestinal complaints in pregnant women: nausea, vomiting, constipation, hemorrhoids, heartburn, etc. To assess the abdomen of a pregnant woman, you are going to also include the size of the uterus. So you're estimating gestational age by where the uterus is on the abdomen. That determines fetal growth, and the position of the fetus is also evaluated in the abdominal exam of a pregnant woman, whether it's, which way it's facing, whether it's breech, etc. That's called Leopold's maneuver. Monitoring of fetal well-being with ultrasound, listening for heart sounds in a pregnant woman, and then presence of uterine contractions. Older adults, the techniques are the same as those for younger adults, but the abdominal wall of older adults becomes thinner and less firm. There's less musculature. I'll give you a funny story. I was in Guatemala doing a clinic down there, and most of these people are very thin. They walk everywhere. And I was examining this elderly lady who was probably about 80 years old. And I never felt, I think she had had like 10 kids. I never felt that loss of abdominal musculature before. Anyway, I could palpate all the way down to her spine. I thought at first I was feeling a mass that was really, really hard. And then I discovered that because she had no abdominal muscle tone left, I was actually feeling the vertebra of her spine. It was really strange. Anyway, so it is a little bit different in older adults, especially as they become thinner and older, and have less muscle tone. The abdominal contour is often rounded as the result of loss of muscle tone in older adults. Some older adults may have difficulty with certain positions, so you may have to modify your exam and use your own judgment in terms of how to complete an exam on an older adult. They also have decreased intestinal motility, and that's associated with aging as well. So they're going to often have constipation, bloating, fecal impaction, obstruction. Gastrointestinal cancers are common as people age, and also pain perception can be altered as part of the aging process. So you can't rely on a lot of the same signals that you can in younger people as far as severity and even infection, because their pain perception is altered. As is their ability to run fever, by the way. So sometimes people can be very, very sick but not run extreme extremely high fevers when they're older. So let's talk about some of the abnormalities in the abdominal exam. In the alimentary tract, we have diarrhea. Acute diarrhea is frequent liquid or loose stools lasting less than 4 weeks duration. So anything over 4 weeks would be considered chronic diarrhea. Now you say, oh my gosh, 4 weeks? Really? Yeah, but that's the definition of what's acute, because some viral infections actually can cause diarrhea that lasts that long. Now, most people are not going to put up with 4 weeks of diarrhea before they come to the doctor. However, just so you know, it's not uncommon for most viral infections to last at least a week of diarrhea. Now, you're lucky if it's the 24-hour bug, but when we're trying to explain to patients, we can, tell them that it's not uncommon for viral gastroenteritis to last up to a week or more. Gastroesophageal reflux disease causes backflow of gastric contents up into the esophagus, causing pain. There's a lack of the closing of that sphincter valve at the top of the stomach, the cardiac sphincter, and that causes the acid to go up into the esophagus, and the esophagus is not lined with the same kind of mucosa as the stomach, so it cannot withstand that acid, and that causes erosion and eating away at the esophagus, which is why, by the way, that chronic reflux disease needs to be evaluated with a upper GI or EGD, because you can get cancer of the esophagus from chronic gastroesophageal reflux disease. Irritable bowel syndrome is a disorder of the intestinal motility. Irritable bowel is typically alternating constipation and diarrhea, although some people are more prone to the diarrhea and some people are more prone to the constipation. But typically it's brought on by stress or different types of food, and most people have had this their whole life. So those are some of the key things that you would want to ask about. Is this a new thing, or is this something that you've always dealt with, etc.? Hiatal hernias with esophagitis. Part of the stomach passes through the esophageal hiatus in the diaphragm and into the chest cavity. That's a hiatal hernia. These are very, very common, and in years past they used to do surgery on hiatal hernias, but they found that they really it does no good, and so many people have them that it's really not that unusual. Unless they're extremely large, of course. Duodenal ulcers, chronic circumscribed break in the duodenal mucosa that scars and heals. Bleeding duodenal ulcers, they cause more of the umbilical pain. Crohn's disease is a chronic inflammatory disorder that can affect any part of the GI tract, producing ulceration, fibrosis, and malabsorption. Terminal ileus and colon are their most common site. Some of these others, ulcerative colitis, stomach cancer, diverticular disease, all of these we'll be learning more about as you get into the management courses. But it's important to remember at this point basically where you would see diverticular disease is going to be left lower quadrant typically. Colon cancer, we want to ask the questions in our history about changes in bowel habits, blood in the stool, black tarry stools, etc. Hepatobiliary system, hepatitis, and cirrhosis. We have inflammatory process that is characterized by diffuse or patchy hepatocellular necrosis in hepatitis, and fibrosis and alteration of the normal liver architecture in cirrhosis. So hepatocellular carcinoma arises in the setting of cirrhosis approximately 20 to 30 years after liver injury or disease onset. About 25% have no prior risk factors for cirrhosis, which means that not everyone with cirrhosis is an alcoholic. Excuse me. Cholelithiasis or gallstones form in the gallbladder with certain substances reach high concentration in the bile, like calcium, and they produce crystals, and that can be formed into stones. Cholecystitis is the inflammatory process of the gallbladder, most commonly due to obstruction of this cystic duct from stones. This can be either acute or chronic. So the gallstones lead to inflammation, and that's called cholecystitis. Then we have the non-alcoholic fatty liver disease. Excessive alcohol intake ranging from steatosis to cirrhosis and even leading to carcinoma of the liver. The pancreas, we can have acute or chronic pancreatitis. Spleen laceration or rupture is the most commonly injured organ in abdominal trauma because of where it's located. So the mechanism of injury can either be blunt or penetrating, but more often blunt, like in motor vehicle accidents. So we always want to evaluate for spleen rupture, and those abdominal signs like the Gray Turner and the Cullen sign are important to evaluate in any kind of abdominal trauma. The kidneys can also be inflamed with acute glomerulonephritis, which is an inflammation of the loops of the renal glomeruli. Hydronephrosis is caused by dilation of the renal pelvis, usually due to a kidney stone which obstructs the urine flow. And that can occur anywhere from the urethral meatus all the way up to the kidney itself. Pyelonephritis is an infection of the kidney itself, not in the bladder, but it's gone all the way up into the kidney and the renal pelvis. And typically patients are much sicker with pyelonephritis, with high fever, flank pain, positive CVA tenderness, etc. Renal abscess is a localized infection within the cortex of the kidney, and renal stones can be formed in the pelvis and try to travel down the ureters to the bladder, but can oftentimes cause obstruction anywhere along that urinary tract. Then we have acute renal failure, which is a sudden impairment of renal function over hours to days, resulting in an acute uremic episode. The kidneys basically stop functioning because of an insult. Oftentimes it has to do with severe infection or some sort of other event in the hospital with acute renal failure. In infants, intussusception is one that we want to be evaluating for. We can have prolapse or telescoping of one segment of intestine into another, which causes an obstruction. That's called intussusception. Then we have pyloric stenosis. In infants, it's hypertrophy of the circular mass of the pylorus, which leads to the obstruction of the pyloric sphincter in the bowel. And then we have meconium ileus, which is distal intestinal obstruction caused by thick inspissated and impacted meconium in the lower intestine, more common in infants. Biliary atresia is a congenital obstruction or absence of some or all of the bile ducts, resulting in obstruction to bile flow. And then Meckel's diverticulum, which is an outpouching of the ileum that varies in size from the small appendiceal process to a segment of the bowel several inches long. And it's usually in the proximity of the ileocecal valve. In infants, we may want to evaluate also for necrotizing enterocolitis, which is an inflammatory disease of the mucosa associated with prematurity and immaturity of the GI tract. A more common thing that you might see in primary care is neuroblastoma, which is a common solid malignancy of embryonal origin in the peripheral sympathetic nervous system. And then Wilms tumor, which is also fairly common, or called a nephroblastoma, is the most common intra-abdominal tumor of childhood, which usually appears at 2 to 3 years of age. Hirschsprung's disease, absence of parasympathetic ganglion cells in the segment of the colon that interrupts the motility of the intestine and causes a megacolon. And then hemolytic uremic syndrome is a triad of microangiopathic hemolytic anemia, thrombocytopenia, and uremia. Fecal incontinence is really common in older adults, which is an inability to control the bowel movements leading to leakage of stool. The three most common causes of fecal incontinence are fecal impaction due to severe constipation, underlying diseases, and neurogenic disorders where they basically lose nerve innervation. And that is the end of our lecture on the abdominal exam. Please review the end of the chapter that discusses a lot of these abnormalities. If you look in your book at the back of chapter 17, you'll see the abnormalities. In particular, review the ones on infants and children. The one thing that stands out in the objective data for intussusception is that sausage-shaped mass that can be palpated in the right or left upper quadrant, whereas the right lower quadrant feels empty. That's that positive dance sign that I mentioned earlier. And it's, again, a sausage-shaped mass in the right or left upper quadrant. That's intussusception. Pyloric stenosis. The one thing to remember that's differentiating about pyloric stenosis is that there's a small, rounded, olive-shaped mass, sometimes palpable in the right upper quadrant, especially after the infant vomits. So remember, small, rounded, olive-shaped mass. That's pyloric stenosis. A meconium ileus can be the first manifestation of cystic fibrosis. In newborns, they'll present with abdominal distension, and usually this is something that occurs in the first 24 hours after birth. With Meckel's diverticulum, the most common objective finding is painless rectal bleeding on examination. Some patients may have intestinal obstruction, which includes abdominal tenderness, guarding, and rebound tenderness. But the most common objective finding is painless rectal bleeding. In children, bright or dark red rectal bleeding with little or if any abdominal pain is common in Meckel's diverticulum. This necrotizing enterocolitis may present as inability to tolerate feedings, and it can present suddenly or progress quickly. They have abdominal distension, vomiting, and bloody stools. They may have a temperature instability and subtle signs of distress. They can be lethargic, have distension, and respiratory distress. A neuroblastoma. This is important to remember. The objective data that's most common with a neuroblastoma is a firm, fixed, non-tender, irregular, nodular mass that crosses the midline in the abdomen. So they typically present as an asymptomatic abdominal mass, but it crosses the midline, and it's firm and fixed and non-tender. It's irregular shaped and nodular in consistency. Then the Wilms tumor, or the nephroblastoma, which is a tumor on the kidneys. This can be felt on the abdominal examination as a firm, non-tender mass deep within the flank area. It's only slightly movable and not crossing the midline. It can, however, be bilateral at times. And also, another characteristic finding is hypertension. So if you have an infant or child with hypertension and you have an abdominal mass, a non-tender mass, think Wilms tumor. It most of the time presents with a painless enlargement of the abdomen or an abdominal mass, which is often found while the parents are bathing their young child. Some patients can have abdominal pain, vomiting, and hematuria with these tumors. Hirschsprung's disease, which is the megacolon, symptoms typically begin at birth with failure to pass meconium in the first 24 to 48 hours. They also include failure to thrive, constipation, abdominal distension, and older infants and young children may present with severe constipation. The examination is consistent with severe constipation, including abdominal distension and stool palpated in the left lower abdomen. So, that's it for the abdominal exam. I hope you find this helpful, and we'll be discussing this later, and let me know if you have any questions. Thank you, and good night.